All right, time to put on our detective hats. We're going to tackle 10 clinical puzzles, and in each one, the diagnosis hangs on a single, crucial, game-changing clue.
So, here's the deal. Your mission is to think like a clinician. In every one of these cases, there's a ton of information, but only one detail really cracks it wide open. The challenge is, can you spot that signal in all the noise? Ready to jump in?
Okay, let's kick things off with round one. These cases are all about pattern recognition, the classics. But you know, even the classics have some tricky lookalikes, so let's see how one single finding can change absolutely everything.
Okay, case one. So picture this. An elderly patient comes in with crampy pain and a swollen belly that sounds like a drum when you tap on it. Two common diagnoses probably pop right into your head. But how do you tell them apart, like right now?
It all comes down to the rectal exam. An empty rectum? That's your smoking gun for a sigmoid volvulus, that classic coffee bean twist you see on an X-ray. But a packed rectum? Well, that's fecal impaction. One simple exam, two totally different game plans.
All right, let's move on to our next puzzle, this time in pediatrics. An abdominal lump in a kid is, let's be honest, terrifying. Your mind immediately goes to cancer. But hold on, what's the one tiny detail here that steers us in a completely different and, frankly, less scary direction?
That one word, tender, changes everything. See, the nasty stuff, like a Wilms tumor, those masses are usually non-tender. A tender mass, especially one that kind of comes and goes, that screams a UPJ obstruction, a blockage that makes the kidneys swell up. That single detail is so incredibly reassuring.
Next up, so you've got this patient, dry eyes, dry mouth, swollen salivary glands. This is a classic triad of symptoms. When you see these three things line up, especially in a middle-aged woman, one diagnosis should be blinking in neon lights at the top of your list.
Yep, this is Sjogren's syndrome straight out of the textbook. It just fits the picture perfectly, right down to that wild 9-to-1 female-to-male ratio. And then you can clinch the diagnosis by finding those key antibodies, anti-Ro and anti-Law.
Okay, ready for round two? Because in these next few cases, getting the diagnosis right is only half the battle. The real puzzle is knowing the protocol. Get the steps in the wrong order, and you could be causing delays or even real harm.
So think this one through with me. You've got a gold miner, major risk factor for lung cancer, right? Silica exposure. The chest X-ray shows something. The gut reaction might be to go straight for a biopsy. But nope, that would be a huge mistake. Look, the sequence here is absolutely critical. After that X-ray, the very next step is always a CT scan. Think of the CT as creating the map. It shows you exactly where the lesion is, what it looks like, and how far it might have spread. You just can't plan a bronchoscopy without that map. It's step by step for a reason.
Oof, this one is high stakes. A deep vein thrombosis, a DVT in a pregnant patient. You've got to treat the mom's clot, but you absolutely cannot harm the baby. And here's the kicker. One common anticoagulant is totally fine, while another is an absolute no-go. Do you know the difference?
And the difference is night and day. Low molecular weight heparin, or LMWH, that's your go-to. It's safe because it doesn't cross the placenta. But warfarin? It's a disaster waiting to happen. It's teratogenic and can cause fatal bleeding in the baby. This is one of those rules in medicine you just never break.
All right, let's switch gears to a psych puzzle. You've got a patient with a history of depression, but then they mention this past episode, this week where they barely slept, got a ton done, couldn't stop talking. Ding, 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 that's the clue. That wasn't just a good week, that was hypomania. And that detail changes the diagnosis from depression to bipolar II disorder, which changes everything about the treatment.
And you have to get this right, because if you treat bipolar II depression with a standard antidepressant, like an SSRI by itself, you can actually push them into a full-blown manic episode. It's so dangerous. The first-line choice is actually something like lurasidone, or quetiapine, which works as a mood stabilizer.
All right, let's head into our final round. And these last few cases, they're not about some rare disease or a super complex protocol. They're all about professional judgment. They're about spotting those quiet but critical red flags that scream, "Pay attention to me."
So, a patient comes in with low back pain. Happens all the time, right? But this patient has a history of breast cancer. And suddenly, that common complaint could be hiding something much, much more serious. What's the most important detail in her entire story?
It's that cancer history. No question. It is the single biggest red flag for metastatic bone disease. I mean, look at this number. A staggering 80% of all bone metastases come from just 5 cancers: breast, prostate, lung, thyroid, and kidney. For a patient like this, new back pain is a potential emergency until you prove it's not.
Now, this next one is a different kind of puzzle. It's about knowing when a red flag isn't a red flag. A mom is worried her 12-year-old daughter, who's a vegetarian, might have an eating disorder. But is this really a cause for concern, or is it just a kid being a kid?
When you lay it out, the picture becomes really clear. Our patient, she checks all the boxes for healthy development. Her BMI is normal, she feels good about her body, and her diet is about ethics, not restriction. The real red flags for an eating disorder, a super low BMI, distorted body image, physical signs like knuckle calluses, they're just not there. The right thing to do here? Reassure the mom.
Okay, our final case, and this one is all about ethics. You witness a colleague, another doctor, practicing while they're clearly intoxicated. It's an awful, uncomfortable situation. But from a professional and legal standpoint, is there any gray area here? Any room for doubt about what you have to do?
The answer is absolutely not. There is zero gray area. This is called mandatory notification. It's not a choice, it's a legal requirement. The law is there to protect patients, period. And it also protects you, the reporter, when you act in good faith. Your duty is crystal clear. You have to report it.
So, we've gone through 10 different puzzles. What's the one thing they all have in common? It's not about memorizing a million facts from a textbook. It's about a much more refined, much more important skill.
It all boils down to this idea. Clinical excellence isn't about knowing everything. It's about being able to spot the one single detail that changes everything. In every case we looked at, the answer was right there in front of us. The empty rectum, the tender mass, that 1 week of high energy, the cancer history. It's about training your brain to see that crucial signal.
And really, that's the challenge, isn't it? The clue is always there. The only question is, what will you see? Thanks for joining me for this explainer.